Hi everyone, good morning. I'll wait until 10 before I share my screen. Welcome to today's session with me at Tipton Training, online of course. I hope you're all safe and staying home as we all should, to keep you safe, me safe, everyone safe. I'll share my screen now. We have aimed for a 1 hour long webinar, which I'll try to make as interactive as possible. We now have over 150 attendees, which is great. You'll always be able to raise your hands if for some reason there's a problem. You'll be asked a few questions along the webinar, which I hope you'll be able to answer. And at the end, there will be a Q&A session to answer some of the questions that may come up during the presentation. And of course, you'll then be able to email me at any time to clarify any other questions. 9 a.m. We are close to 100 attendees. I'll screen so we can start today's webinar. Can you please raise your hand if you can see the screen? Brilliant. Amazing. Screen full of hands. So let me just put you here at the corner. Louise, all good to go? Brilliant. Great. So this is where I come. I'm Hugo. I'm a specialist periodontist. I've trained in Lisbon, and I trained as a specialist in Lisbon as well, and I moved to the UK about 7 years ago. This is where I live. This is where I should be working today, but I'm not. Unfortunately, most practices are closed and we are only seeing emergencies. Hopefully this will all get sorted and soon we'll be back. So this is where I am. Not exactly down there by the beach, because although we are close to this paradise, we are meant to be home. So I'm somewhere behind the hills in Portugal. This is a small village called Azeitão, south from Lisbon, and this is where I've been spending the last few weeks. But this is what brings us today to this webinar. So we'll be discussing the new classification scheme for periodontal and peri-implant diseases and conditions. I'll try to raise some of the reasons why this new classification has been published. We'll go through the details of the new classification scheme as it was presented in Europerio 2018 by the European Federation of Perio and the American Academy of Perio. We'll then focus, most of the time, is with the implementation, the clinical implementation of this classification in the United Kingdom. Of course, we'll go through some clinical cases, and that's where we'll try to make this as interactive as possible. We'll come to the conclusions, and then at the end, hopefully within the hour, we'll come to a few minutes with Q&A. So why a new classification on periodontal conditions? So first, it's important to understand that a classification is an international language, and it will help with surveys of disease prevalence. But in our daily practice, it also helps us to communicate our diagnosis and our prognosis with our patients and also with our colleagues. And at the end, it also helps to ensure the implementation of the correct treatment options. So it's been almost 20 years since the previous classification. So we had In 1999, Armitage and collaborators published the previous classification. And during the last 20 years, we've been seeing some advances in knowledge, both from the biological, but also from the clinical perspective and research. We nowadays try to make everything with precision and tailor-made to our patients as an individual. So this new classification aims to also include aspects such as severity, extent, but also the patient individual susceptibility to the progression of a disease. This classification aims to be a live system. What this means is that they want to be able to have the space to incorporate future advances in knowledge, such as, for example, biomarkers that we know will come up in the future. Ian Chappell, one of the authors responsible for this classification, stated that although it may seem at a first glance quite complex, the classification is fairly straightforward and quite pragmatic. So now that we understand why they've decided to publish this new classification, what and how was it first presented in 2018? So a group of scientists from the European Federation and from the American Academy of Perio got together in 2017 at the World Workshop, and they came up with a classification that was then presented to us all in 2018. And this table summarizes this classification. So they've divided the perio conditions into 4 groups. The first group was periodontal health, gingival diseases and conditions. The second group was periodontitis. The third group was other conditions that affect the periodontium. And the fourth group was peri-implant diseases and conditions. And we'll go through every single one of these groups in detail. So the first group is periodontal health, gingival diseases and conditions. This is something new. So in the previous classification, there was no such thing as periodontal health and gingival health, whereas plaque-induced gingivitis or any gingival diseases that are not dental biofilm induced are pretty much the same thing as before. So let's go into detail in what differentiates periodontal health and gingival inflammation. So periodontium, a reduced periodontium induced or not induced by periodontitis, the differentiating factor is the bleeding on probing. So if we have a percentage of bleeding on probing that is below 10%, then we are facing health. If it's intact periodontium, no bone loss, no attachment loss. If it's reduced periodontium not caused by periodontitis, then we have some attachment loss like recession or attachment loss caused by a crown lengthening, but we may or may not have radiological bone loss. Whereas if we have a patient within the periodontitis group that has been treated, we can have health with no pocket, no bleeding on probing, so less than 10%, but with signs of bone loss on the x-rays and definitely some attachment loss. If we have more than 10%, then we are facing gingivitis. And even in a patient that has been treated with periodontitis, if there are no pockets deeper than 3, and because we have bone loss and interdental attachment loss, if the bleeding on probing percentage is over 10, we have gingivitis in a patient with history of periodontitis. And this is with this European Federation of Perio classification. The second group has all the periodontitis, such as necrotizing periodontal disease, which are more or less the same as the 1999 classification. One of the biggest changes is within the group of periodontitis. So periodontitis, such as we used to classify it into chronic and aggressive, that does not exist any longer. So what we now need to do is we need to stage, which will give us the severity of periodontitis, and grade, which gives us the susceptibility of the patient to the progression of disease. And in order to stage and grade, the European Federation and the American Academy have given us a couple of tables. So for severity, what we need to look into is the incidental clinical attachment loss at the site of the greatest loss. And if it's 5 or more than 5 millimeters, then it will be a stage 3 or stage 4. If we look into the X-ray with the worst bone loss, if it's within the coronal third, it's going to be stage 1 or 2. If it extends to the mid third or the apical third, it's going to be a stage 3 or 4. And the criteria that this classification uses the most to stage periodontitis is the number of teeth that were lost due to periodontitis. So if we have lost no teeth due to periodontitis, it's going to be a stage 1 or 2. If we've lost up to 4 teeth due to periodontitis, it's going to be a stage 3. More than 4 teeth lost with periodontitis, it's going to be a stage 4. And you are probably asking, how do we know? So most patients may not know if the reason why they've lost their teeth was gum disease. But we can always ask if there was any mobility, if the tooth was causing any pain, or if it was just a decay, if it was a failed endodontic treatment. So from the history, we can probably tell if the reason was periodontal or not. In terms of complexity, we should also look into probing pocket depth, and if it's below 5, then it's stage 1 or 2, and the bone loss pattern will mostly be horizontal. If we have vertical bone loss with pockets of 6 or more, with furcation involvement grade 2 or 3, then it's a stage 3. And usually stage 3 can be dealt with periodontal treatment alone. If we require complex rehabilitation to treat the case, then it's a stage 4. For any of the stages, we also need to classify these periodontitis in terms of extent and distribution, and the threshold is either 30%, below 30% for localized, over 30% for generalized, or if the bone loss is localized around first molars and incisors, then we have the molar incisor pattern that was very classical to localized aggressive periodontitis from the previous classification. To grade periodontitis, we'll need to look at primary criteria and grade modifiers. The primary criteria are either the long-term follow-up of the bone loss, and if we have x-rays from the same patient over the time, if we see no evidence of bone loss over the last 5 years, then it's going to be a grade A periodontitis, so a slow rate of progression. It's going to be a moderate rate of progression if we have up to 2 millimeters of bone loss over the last 5 years, or a grade C if it's more than 2 millimeters of bone loss over the last 5 years. If we don't have this long-term follow-up and we only have a cross-sectional assessment of that patient, then we should be using the periapical radiograph that shows the worst level of bone loss and divide the percentage of bone loss by the age. The threshold for grade A is below 0.25. If the ratio bone loss by age is between 0.25 and 1 is grade B, and if it's over 1, it's going to be grade C. Also, if you look into the amount of plaque and tartar and see if a lot of plaque comes with a lot of destruction, then it's likely to be a grade A. If there is no plaque at all and quite a severe state of disease and progression, then it's going to be a grade C. And in terms of the risk modifiers, the European Federation and the American Academy have stated that if the patient smokes more than 10 cigarettes a day, it's going to be automatically a grade C periodontitis. If the patient smokes less than 10, it's going to be a grade B, and only a grade A if it's a non-smoker. And similar happens with diabetes. A normal glycemic or a patient with no diabetes is going to be a grade A. If there's history of diabetes with a well-controlled blood sugar level, it's going to be a grade B. Patients with HbA1c over 7% are patients into grade C automatically. The third group within this new classification is other forms of periodontal diseases and acquired conditions. And these can be abscesses, endoperioral lesions, occlusal trauma, recession, lack of keratinized gingiva, or tooth-related fractures such as root fractures. And the fourth group is peri-implant disease and conditions. These we will focus on Friday. So come along, and on Friday we'll go in detail through these four conditions that are part of the peri-implant diseases and conditions. So this slide summarizes this classification, and you need to know that if you're doing research, you should be following this international classification system. But if you're not, and if you're working in the United Kingdom, then the British Society of Periodontology have issued guidelines that aim to implement this classification into clinical practice. So over a year ago, they've published a series of papers that will introduce this implementation, and we will go through the details of how to do this. So I believe, and what the British Society of Perio recommends, is that we follow a few steps before we reach a diagnostic statement. The first step is to determine the type of disease. So again, here we have a table, and within this basic classification of periodontal disease and conditions, we have three groups. The first group is periodontal health, gingival diseases, and conditions. Again, in periodontal health group, we have intact and reduced periodontium. For gingivitis, it can be either induced by plaque, and it can be within an intact periodontium, or reduced periodontium. And the third group is gingival diseases and conditions that are not associated with plaque. To note that within this implementation, the reduced periodontium category is only for reduced periodontium due to causes other than periodontitis, such as, for example, crown lengthening. So if we want to differentiate between health and gingivitis within the intact periodontium group, we know that we don't have any attachment loss. We know that there is no bone loss. We should not be seeing any pockets deeper than 3. The factor that makes the difference is, again, the bleeding on probing. So if we have a patient with no signs of bone loss, no pockets deeper than 3, and there's less than 10% of bleeding on probing, it's periodontal health. If we have more than 10%, it's gingivitis. If it's between 10 and 30, it's going to be localized gingivitis. Over 30%, it's generalized gingivitis. Within the reduced periodontium group, that is not associated with periodontitis, it's very similar. Difference is that we'll definitely have attachment loss, either due to crown lengthening, localized recession. We may or may not have bone loss as seen on the radiographs. We will have no pockets deeper than 3. And again, if we have less than 10% bleeding on probing, it's going to be a healthy periodontium in a reduced periodontium, and it's going to be gingivitis in a reduced periodontium if it's over 10%. And very similar with successfully treated periodontitis patients, where healthy represents stable periodontitis, so no pockets deeper than 4, And if we have any 4 millimeter pockets that cannot be bleeding on probing, and we have less than 10% of bleeding on probing, although we may have attachment loss and definitely bone loss, and it's going to be in remission if, although we have no pockets deeper than 4, and we have bone loss and clinical attachment loss, the bleeding on probing score is over 10%. So the second group within this basic classification is other conditions that affect the periodontium. These can be those systemic diseases that affect periodontal supporting tissues, such as Down syndrome, some hematological disorders, some other genetic disorders. It can also be periodontal abscesses and endoperioral lesions. It will include recession, lack of keratinized tissue. It will include occlusal trauma and also tooth and prosthesis related fractures. And the third group within this basic classification in terms of the type of disease is all other forms of periodontitis. Necrotizing periodontal diseases, pretty similar to the previous classification, and periodontitis. And all patients that show evidence of historical or current periodontitis should have a diagnosis of periodontitis straight away. And these patients will need to be staged and graded. The second step. So once we have the type of disease, we'll need to determine its extent. It's going to be localized gingivitis if it's between 10 and 30% of bleeding on probing, like I said, generalized gingivitis if it's over 30%. In cases of periodontitis, it's going to either be localized if we have up to 30% of the teeth affected. More than 30% of the teeth affected, it's generalized periodontitis. And if it's only affecting incisors and first molars, it's going to be incisor molar incisor pattern. So then if we have a diagnosis of periodontitis, we'll need to stage. And like I said, stage relates to severity. We don't need to look at all those factors that I've showed you before. We'll only need to identify the tooth that shows the worst level of intradental attachment loss or intradental bone loss. And if you have a periapical x-ray of that tooth, you'll need to identify where the bone level is. If it's within the apical third of the root, then it's a stage 4. If the bone level is within the mid third of the root, it's going to be a severe stage 3 periodontitis. If it's within the coronal third, but more than 2 millimeters from the CJ, it's going to be stage 2. And if it's within the first 15% of bone loss, it's going to be a stage 1. In terms of grading, again, very easy. Use the same periapical radiograph that you've used for staging and determine the percentage of bone loss at the worst affected tooth. Divide that percentage by the age of the patient and you'll have a ratio. If the ratio is above 1, it's going to be a grade C, so rapidly progressing periodontitis. Grade B, moderate between 0.5 and 1. And if the ratio is below 0.5, is A. And as you can probably see, these thresholds are slightly different than the ones published by the European Federation and the American Academy of Perio. And this was changed to make it easier in general practice to calculate this ratio. So if you have a patient that is 50 years old and has lost more than 50% of bone at the worst affected tooth, that means it's a grade C. Whereas if you have a patient that is 70 years old and has lost less than 35% of bone at the worst affected tooth, it's going to be a grade A. Most of the patients we see will probably be classified as grade B. So the fifth step is to establish the current disease status. So we need to know whether we are facing someone that's stable or unstable. For cases of periodontal health and gingivitis, we know gingivitis is reversible, and we can, if we control plaque or the factors that are causing gingivitis, go back to periodontal health. Once we reach a diagnosis of periodontitis, there's no way back. So we may have a stable periodontitis, but it will always be periodontitis. And periodontitis will be considered stable if we don't have any pockets deeper than 4, or any pockets of 4 that we have cannot be bleeding on probing, and we won't have more than 10% of bleeding on probing sites. If we have no pockets deeper than 4 and no bleeding on probing on pockets that are 4 millimeters, but we have more than 10% of bleeding on probing percentage, then it's going to be periodontitis in remission. If we have pockets of 5 or more, or pockets of 4 that bleed, it's going to be a currently unstable periodontitis. The final step is to determine the risk factor profile. So smoking more than 10 cigarettes puts the patient at a higher risk of disease progression, and that should be highlighted in the diagnostic statement. And the same thing with uncontrolled diabetes, where the HbA1c level is above 7%. And the diagnostic statement that we reach after we follow these steps can be something as, for example, generalized periodontitis, stage 4, grade C, currently unstable, and the risk factor a smoker. So this implementation aimed to still use BPE as a screening tool. And therefore, the BSP has produced a couple of flowcharts that help us to use BPE as it was established in the 2016 guidelines by the BSP, and then work with the BPE codes to go into this new classification. So for codes 0, 1, and 2, where we can either have periodontal health or gingivitis, all we'll need to identify is the percentage of bleeding when we score the BPE full mouth. If we don't have more than 10% of bleeding sites, then it's gingival health. If we have between 10 and 30%, it's going to be localized gingivitis. If we have more than 30% of bleeding on probing sites, then it's going to be generalized gingivitis. If we score our patients with any code 3, then we should carry out initial periodontal treatment at the quadrants that have a code 3, and 3 months later reassess. If no pockets deeper than 4 are present, and if our radiographs don't show any signs of bone loss, then this patient will go back to code 0, 1, or 2 and keep being seen for regular checkups. If, in contrary, the pockets have not settled and we still present with pockets above 4, or there is radiographic signs of bone loss, then this patient will be treated as a code 4. So any patient with code 4 or 3 that did not respond to the initial treatment will need to be fully, and that means full mouth 6-point pocket chart, radiographs where signs of bone loss need to be assessed. Then we'll need to determine the extent of the disease, knowing whether it's molar incisors, if it's localized, up to 30% of teeth affected, or generalized, more than 30%. And afterwards, we need to stage and grade. To stage, we'll look into the radiograph that shows the worst affected tooth and identify the level of bone loss. Within 15%, stage 1, stage 2, if the bone level is within the coronal third of the root, if it's within the mid third of the root, stage 3, and then stage 4, if it's at the apical third of the root. Grading, use the same X-ray, identify the percentage of bone loss at the worst affected tooth, divide that by the age of the patient, and if the ratio is below 0.5 is grade A, 0.5 and 1 grade B, above 1 is grade C. We have the diagnosis, the type of disease, we have the extent, we have the stage, the grade. Now we'll need to know if the disease is stable, less than 10% bleeding on probing, no pockets deeper than 4, no bleeding on probing on pockets of 4 millimeters, or currently in remission, if similar as before, but with more than 10% bleeding on probing, or unstable if we have any pockets of 5 or above 5 or 4 millimeter pockets that bleed. And the last step before we reach the diagnostic statement is identifying whether the patient smokes or if he has a suboptimally controlled diabetes. So far we've been going through theory. Now we'll go into a few clinical cases. The first 3 clinical cases have been published at the British Dental Journal with the implementation of this new classification. And then the last case is one of my cases from practice. So case 1 is a case of a female patient who is 49 years old, presents with good general health, never smoked, and she tells us about history of several courses of periodontal treatment carried out by the general dentist. These are the initial pictures that show in the clinical scenario generalized recession. There's already at least one missing tooth, generalized staining. In terms of periodontal chart, we see generalized recession, generalized pockets, deepest one being 8 millimeters. We have mobility, grade 1 and grade 2 at the upper left, 8. Several sites that show bleeding on probing. And then the periapical radiographs of this case that show generalized horizontal bone loss and some localized vertical defects. So let's try this interactive poll. My question now is, we know it's periodontitis. There's no question about that. We know it's generalized because we've seen bone loss in more than 30% of the teeth. We know it's unstable because we've seen pockets deeper than 5. We've seen generalized bleeding on probing. What we don't know yet is what's the grade and what's the stage. So what I want you to do is, let's see if this works, vote on which tooth do you think is the worst affected. Can you all see the first question? Please raise your hand if you can. Great. Just vote for the first one. No one has voted yet. Brilliant. We have 235 watching webinar, only 5 have voted. Everyone is still awake? Here we go. Okay, so the vast majority of you believe that the worst affected tooth is the upper right 5. Some of you are thinking about the upper left 7 or the lower left 5. Let's end this poll. And the majority is right. So the worst affected tooth is the upper right 5. So if you look into the upper right 5 in detail, all we'll need to do is identify if the bone level is within the apical third, between at the mid third, or within the coronal third. I believe it's within the apical third. It's going to be a stage 4. If we divide the percentage of bone loss here, which is around 80–90%, by the patient age, which is 49, then we will definitely have a ratio above 1. So the diagnosis for this case, it's going to be a generalized periodontitis, stage 4, grade C, currently unstable. The second case is of a young girl, 19 years old, good general health, a never smoker, and no history of periodontal treatment. These are the clinical pictures, and because there was no history of periodontal treatment, before we start any periodontal assessment, we need to screen. So at the screening, the BP scores were 4 everywhere with furcation involvements at the posterior sextans. So with BPs of 4s, we definitely know that we need to do a full 6 points pocket chart. And this is what you get. So generally, the gum level is where it should be, so no signs of massive recession, but we definitely have generalized pockets, and pockets that are definitely above 5, reaching 7 millimeters. Generalized bleeding on probing, some teeth that show grade 1 mobility, so it's definitely a case of a generalized, unstable periodontitis. Looking at the periapical status, we can see that there is generalized horizontal bone loss, and the worst affected tooth is the upper right 4. Let's launch the poll again. And now look into question 2. So considering the upper right 4, where do you think the bone level is at? Next time we'll definitely need to do these questions separately and not all in one group only. So let's vote for case 2. Oh, it's pretty balanced between stage 3 and stage 4. So remember, stage 3 is if the bone loss is within the coronal third, stage 4 within the apical third. So what you need to do is divide the root in 3 sections and then identify where the bone level is. Brilliant. So the majority is now leaning towards stage 3, and that's correct. So stage 3 is the correct diagnosis. So it's a generalized periodontitis because we had more than 30% of teeth affected. It's a stage 3 because the upper right 4 showed the bone loss at the mid-third. Grade C, because if we divide the percentage of bone loss, which is definitely above 50, by 19, which is the patient age, it's going to be a grade C, and it is currently unstable because we have pockets above 4 millimeters and we have generalized bleeding on probing. So the third case is a female, 37 years of age, good general health, and a never smoker. And this patient presents to us with no history of periodontal disease. So again, after our clinical assessment, we do BP screening. And my question for this case is, and now we need to have all of you answering. So at the moment we have over 200 people. Let's try to get everyone to vote. So case 3, considering the BP scores you can see on the screen, where should we be doing a 6-point pocket chart? There's a race between full mouth 6-point pocket chart and just doing the 6-point pocket chart at the posterior sextans, where we have scores of 3 and 4. But 92% have voted for a full mouth. So we definitely should be doing a full mouth pocket chart, because once you identify any sextant with a code 4, then it's mandatory to do a 6-point full mouth chart. You can only, or you should only be doing a sextant pocket chart if you have a code 3 at the reassessment, so 3 months later. But in this case, in this scenario, we definitely need a 6-point pocket chart, and this is what we see. So we see fairly localized pockets around the upper right 6, quite deep, 7 millimeters with bleeding on probing, so definitely unstable. Otherwise, another pocket of 5 at the upper left 6, at the lower left 6, and at the lower right 6. No signs of clinical recession, some mobility around some of the upper teeth. Localized radiographs, so we have a panoramic X-ray and then individual periapicals around the areas where we see deep pockets. And we can clearly identify the lower left 6 as being the worst affected tooth, and the bone loss is within the mid-third, so it's going to be a stage 3. And if we divide 50 by the age of the patient, we come up with the grading as well. So in this case, we have a molar incisor pattern periodontitis because it was only affecting first molars. It's a stage 3, grade C, currently unstable. And the final case, which no one has ever seen, because it's one of my patients from practice. It's a 40-year-old male patient, general health, never smoked, and he presents to us with history of periodontal treatment carried out by his general dentist. This is the pocket chart. You can see very deep pockets, up to 12 millimeters on the lower right 6, 11 millimeters at the upper left 3, some grade 2 mobile teeth, furcation involvements, class 1, class 2, bleeding on probing in localized sites. I can tell you the plaque control when the patient first presented was very good. He had generalized recession down the lower incisors, but no pockets. These are the periapical radiographs I took at the initial consultation. And what I want you to tell me is, looking at the worst affected tooth, which is the lower right 6, knowing the age the history and seeing period chart, let's vote for case 4. What is this patient's diagnostic statement? So now everyone is waking up. We have over 50 attendees voting. The first option is ahead in the race. Some of you are questioning between localized and generalized, and a few between stage 3 and stage 4. I'll give you 10 more seconds before I close the poll. Great. So we have 53% voted stage 4, grade C, generalized periodontitis. So looking at the period chart, you may believe it's localized because the pockets seem very localized. But what you need to consider is number of teeth that have bone loss. And all the lower teeth, except the premolars, show recession and therefore incidental attachment loss and bone loss. So this is definitely a case of generalized periodontitis. Then if we look into the lower right six, the bone loss with this vertical defect goes all the way to the apical third of the root. So it's definitely a stage 4. And if you divide the percentage of bone loss at the lower right six by 44, it's definitely a grade C. So the diagnosis in this case is a generalized periodontitis, stage 4, grade C, currently unstable. Conclusions. So for the last 45 minutes, I was presenting this new classification scheme that came from the 2017 World Workshop that got the European Federation and the American Academy of Perio together. And we've also went through the way the British Society of Perio have implemented this classification in the United Kingdom. It's a contemporary and future-proof classification system. The major novelties are the introduction of staging and grading for periodontitis. We no longer use aggressive and chronic periodontitis as a diagnosis, and there's been an introduction of 2 new groups, periodontal health and peri-implant conditions, which again, we will be addressing this coming Friday. Within the staging and the grading, which is designed to capture the severity and the susceptibility, makes this a very tailor-made precision medicine classification. With the way we've implemented the classification in the United Kingdom, periodontitis diagnosis cannot be reversed, and we need to incorporate the current status of the disease into the diagnostic statement. And for that, we use the pockets and the percentage of bleeding on probing. And this classification aims to provide a simplified staging and grading system, way easier than those 2 tables I showed you at the beginning from the international classification, and also incorporates the BPE screening tool as a starting point. The diagnostic pathway includes several steps, as you've seen. So we need to first determine the type of disease. So is it gingival health? Is it periodontitis caused by plaque? Is it other form of periodontitis? Is it recession? Is it peri-implant conditions? And we need to determine the extent of the disease. And if it's periodontitis, stage and grade. It's mandatory that we determine the current state of disease to know whether it's stable, unstable, or in remission. And again, the criteria is percentage of bleeding on probing sites. And then the final diagnosis is a diagnostic statement. And we can't forget to add on the relevant risk factors. And they should be documented and regularly updated. Any questions we'll be able to answer during the next 10 minutes, or feel free to email me and I'll be happy to answer all the questions you may have. So let's go into some of the questions. So where do ex-smokers fit in this table? If it's an ex-smoker that is not on e-cigarettes, then it's a non-smoker. Although this patient needs to know that he is still at a high risk of disease progression and the treatment may not give the same response if they've stopped smoking a few months ago. Usually it takes up to 10 years for the effects of smoking to disappear, but in terms of the classification, we should not put it as a risk factor, although I would probably advise you on the notes to write ex-smoker of X number of cigarettes a day, quit X number of months, years ago. With e-cigarettes or patients that vape, I would consider them smokers. So I would definitely put that on the diagnostic statements. That's one of the questions I've asked the international committee from the European and American associations of perio, and they said it's a work in progress. So another question, if you see a patient that presents with 5mm recession, would you classify them as perio patients, as the patient could currently have no pockets or bleeding on probing and good oral hygiene? So would they still be classed as a perio patient? And then what would you tell the patient as a diagnosis? So as you've seen, there were 4 groups within this basic classification. This is definitely not a patient with periodontitis. It's a patient with a recession, which was on group 3, other conditions that affect the periodontium. The international classification will then classify recession into recession type 1, recession type 2, and recession type 3. This is based on a classification published in 2011 by Cairo, which follows Miller's classification that we all use in clinical practice. So definitely needs to diagnose. It's definitely not periodontitis. It is a case of recession, and you'll just need to classify it according to Cairo if you want to use the most up-to-date classification. So with the BSP guidelines, we disregard missing teeth. We do, although if you know a patient has lost a tooth recently due to periodontitis, so guessing that the bone level of that tooth was within the apical third, you may say that that periodontitis is a stage 4, even if the teeth that are present don't show any bone loss up to the apical third. So that's something that can modify the staging of periodontitis. Some of my patients have had a 5mm for years. Does this make him unstable? Again, this the way the classification was implemented in the UK considers that if you have patients with pockets of 5 or even 6 millimeters that do not show any bleeding on probing, and this is really important, and that seems stable for years, these can also be considered stable. So there's on paper published by the BSP at the British Dental Journal in early 2019, they do raise this question, and you can consider that patient to be stable. Francesco asks, would you do a 6-point pocket chart on a patient with poor oral hygiene, generalized gingivitis at the first appointment? Would you be concerned about false pockets in your 6-point pocket chart? So if you have BPEs of 4 at any site, but you suspect this is a false pocket, and this is one of the downsides of BPE, is that a BPE of 4 does not necessarily mean bone loss, periodontitis. You may take bite wings. And bite wings will allow you to see if there's any signs of bone loss. So if you have BPEs of 4, you suspect it's false pocket, you take bite wings, and you don't see any signs of bone loss, no, I don't think you should be doing a 6-point pocket chart unless you want to record what changes with the initial treatment. But I would say I would treat this patient as a code 3, so do the basic periodontal treatments with oral hygiene instructions, motivation, and full mouth scaling, reassess after a couple of weeks, and if BPs of 4 persist, then you may need to do localized root surface debridement. I hope this has answered your question, Francesco. Warren asks, should we be doing a full 6-point pocket chart on the patient on the first season? DP scores are 4. So I've just answered this question. Would aids in assessment? So for BPE, wisdom teeth are not screened unless there's no other molar in that sextant. For a 6-point pocket chart, yes, I would. We know though that sometimes impacted aids can cause localized attachment loss at the distal surfaces of the 7s. So this may be a scenario where we consider this to be a reduced periodontium not associated with periodontitis. So definitely assess, definitely periapical radiographs, but watch out, it may not be periodontitis. So Hibe has a question about case 2. The mesial of the upper right 4 shows bone loss at apical third. Should be this a grade 4? So let me go back to case 2. So case 2, if you divide this root in 3/3, I would say this is the first third, there is the second, and this is the third. So I would say this bone level here is within the mid-third, very close to the apical, but not quite there. So Hiba, I believe the mesial of the upper right 4 is in the mid-third and not the apical. If it was on the apical third, definitely a grade 4. Not grade, stage 4. If a patient presents with 6 millimeter pockets with no bleeding on probing, would you continue doing a second round of RST to reduce the pocket depth, or will you just monitor it and put the patient on maintenance? It really depends. If this is the only pocket that is left, if there's no bleeding on probing, I would probably start a period of maintenance. And at 6-month reassessments, following maintenance with the hygienist every 3 months, if that pocket persists being 6 with no bleeding, I would probably just keep monitoring it. If it starts bleeding or if it gets deeper, then definitely another course of non-surgical or eventually considering surgery. Although with 6 millimeters, I would probably go for non-surgical again. Be careful with the patterns of bone loss, because if the 6 millimeter pocket is associated with a vertical defect, we are likely to have a resolution of the pocket with the formation of a long junctional epithelium. So although we know a long junctional epithelium is as strong as the normal junctional epithelium, that patient is at a higher risk of disease progression. Is it the responsibility of the hygienist or dentist to do the initial pocket chart and subsequent pocket charts? When would it involve referral to a specialist? So if you follow the BSP guidelines, you should always be assessing, screening, diagnosing every single patient. When should you treat? You are able to treat any cases of periodontitis. Up to BP codes of 3, you should provide initial treatment unless there is systemic compromise of the patient. For codes 4, you can either decide to do the initial treatment and refer if there's been no response, or you are able to refer straight away. In order to go through the details of these referral guidelines, I would suggest you go to the BSP website, go into their publications, get the Young Practitioner's Guide, and there's a chapter on referral, and it makes it very clear. I hope this helps. Would you do radiographs after doing a 6-point pocket chart to get more clear pictures of which views to take? For example, if pocket's depth is 5 millimeters, then horizontal bite wings are sufficient. In my practice, I always do periapicals around teeth that show pockets deeper than 5. If I believe the patient is presenting with generalized mild horizontal bone loss, then bite wings may be enough. But bite wings may not allow you to see the apex, so it may be difficult to then stage and grade. And for that, you will then need to estimate the percentage of bone loss. So in my opinion, periapical radiographs are the best radiograph to assess and diagnose periodontitis. What would you do in case 4? I can tell you what I did. So like I said, this patient had a very good plaque control and very localized pockets. So I adjusted the size of the incidental brushes, so that would allow the patient to reach the pockets around those localized areas with up to 12 millimeter pockets more efficiently. I carried out one course of minimally invasive non-surgical treatment, and at the reassessment, I usually reassess 8 weeks later, so 2 months, the pockets had all settled. So this patient is now under maintenance, seeing the hygienist every 3 months. And because he has vertical defects, he's booked to see me 6 months after the first reassessment. If no pockets are present at that reassessment, I would keep seeing him once a year, and he would keep seeing the hygienist every 3 months. And I would probably at that stage take a new periapical radiograph to see the defect. Because we know nowadays, and it's well documented, that even with non-surgical, we may be able to regenerate verticals. So this would be a patient that from the beginning I thought maybe this one will probably require minimally invasive perio-regeneration, but it was not the case so far, and hopefully it will not be in the future. Stable, please explain stable and remission. I'll answer 3 more questions because we're now over 1 hour webinar. So please explain stable and remission again. So stable periodontitis means that we don't have any pockets above 4, and any pockets that are 4 millimeters don't bleed. And apart from no pockets deeper than 4, no bleeding on pockets of 4, we cannot have a bleeding on probing score that is higher than 10. In remission means that it's not unstable because we don't have any pockets of 5 or above 5. We don't have any 4 millimeter pockets that bleed. We don't, but we do have more than 10% of bleeding sites, which means that if we consider bleeding on probing as the clinical factor to assess in terms of the stability of the disease, if we have more than 10% of bleeding on probing sites, then we can't really say it's stable, so we say it's in remission. Kirsty, I hope this has answered your question. So 2 more. Would you extract the tooth or leave it as it is? Deborah, what tooth are you asking about? Angel Co. So I would always include teeth that sometimes even look hopeless into the initial treatment course, unless there is no bone support at all. So most of the times I would leave, treat, and reassess. No extractions unless they are really hopeless. How would you class a user of a vape in this? So that's something we've discussed before. It's not very clear, but we know that nicotine vapes are as harmful for gums as normal cigarettes. And the last question is, if there is just one molar with 6 millimeter pockets in the whole mouth, is it classified as molar incisor pattern? First, you need to know for sure if this is periodontitis, because only a localized pocket of 6 in the entire mouth, it's unlikely to be periodontitis. So I would look into endoperio lesion. I would look into root fracture before classifying this as periodontitis. So a lot more questions were left unanswered. I'll ask you kindly to email them to me. I'll be happy to answer them through the week. I would like to invite you to join us on Friday. The topic will be the classification and the diagnosis of peri-implant conditions, which is something very current and is something that all general dentists should be able to do. It was a pleasure to see you this morning. Hopefully you've enjoyed the seminar. Stay safe. Bye-bye.